Hi, this is Brian Kim. I'm going to share with you case number 168 in the Best Way to Do Cataract Surgery series. This is a 1 to 2 plus dense lens, small pupil, also IFIS, and the lens won't spin. Once I remove that first heminucleus, the lens doesn't spin. You'll see how I'm going to deal with that. And also the wound won't seal. And so what would you do if you encounter these situations? How would you deal with a lens that won't spin? And if you have trouble sealing the wound, what would you do next? So I use a cotton tip to steady the eye, and this is a corneal marker which will help me to center and size a rhexis. Holding the eye with the cotton tip, holding it steady, and this is my paracentesis incision, first on the right side and the left side. After that, making sure I'm flat to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. Using the cotton tip is very important to help control the eye with these maneuvers. This is intracameral lidocaine and then some intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium, flatten the anticapsule, and you can see there's a little bit of viscodilation as well, which is nice. Using the cannula to hold the eye, and this is a triplanar corneal incision, I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and once I'm ready to enter, you can see I move that cannula towards me, which allows me to turn the eye towards me, and then I'm able to enter. Very controlled way, passive fixation of the eye. This is the sharp tip Haldane forceps. I go in sideways and then straighten out, puncture the center, very well controlled, minimal capsule and zonule stress, grabbing the right side of the tear, going around circumferentially, again using the corneal mark that I made as a guide for the size and centration of the rhexis. Low profile forceps, well controlled, minimal fluid egress, minimal radialization forces with these forceps. Finish off the rhexis. This is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down. Get a nice wave here. Decompress on the left side, sweeping under the rhexis edge on that side. Hooking the peripheral lens on the right side. It's a little bit stubborn. I'm able to rotate it just a little bit. But again, it's a little bit stubborn. And whenever that happens, that should clue you in. And sometimes in these cases, the lens won't spin. Irrigating the surface of the eye. Adjusting my sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, you can see how I'm pronating my hand with the chopper, leading off with the tip, getting under the rhexis edge contra-incisionally, hooking the peripheral lens, hooking the phaco tip vertically sub-incisionally with the lens, crushing the lens in half. That's double chop. You saw how fast that was. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, and it fractures the right heminucleus in half. Using some vacuum to lift that first quadrant up, using the chopper to shield the pupillary edge here. You see what I'm doing there, trying to shield the pupillary edge. It didn't really quite work, so I'm going back and performing another cross chop maneuver, making sure I get good fracturing. And now I see there's good fracturing there. Turning the lens a little bit. And so you can see I'm going to show in slow motion double chop and cross chop. Pronating my hand, sliding underneath the epinuclear ridge, leveling out, straightening out once I'm at the lens equator, rotating the phaco tip vertically sub-incisionally. Look how vertically I'm rotating that phaco tip. Getting the instruments around the lens, crushing it completely in half and fracturing it. That's double chop. Again, rotating that phaco tip vertically is really a very important component for this technique as well. Not only hooking the lens at the equator with the chopper, but also rotating that phaco tip vertically. I'm placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip. And again, the phaco tip is acting like a chopping block. The chopper is chopping and cutting the lens. It's the active instrument with the cross chop. And the phaco tip is a passive instrument. It is a chopping block. So the crushing of the lens between the instruments, it's what helps to execute the cross chop maneuver. You can see I'm using the chopper to shield that iris and retracting the iris as I was trying to grab that first quadrant. It didn't want to come out. And so I'm going to execute another cross chop maneuver. Very easy, very well controlled. Again, there's no ultrasonic energy or vacuum being used at all during these maneuvers. You can see the right side panel, there's nothing. It's just using infusion. Fracturing that lens again in half one more time. I'm going to rotate the lens piece a little bit. Getting under it with the chopper one more time, hooking the peripheral lens, again, doing a cross-chop maneuver, fracturing the lens in half. Now I'm just using the chopper to kind of lift the piece up. You can see it's rather stubborn. The lens pieces aren't wanting to come. So what am I going to do here? Instead of trying to torque the lens within the bag and stress the zonules, because that's what's happening, there's obviously some still adhesions between the lens and the bag itself, and so there's no reason to do anything more, no reason to stress the zonules. Just go in and re-hydrodissect. It's really not that hard. I'm re-hydrodissecting, and then I'm using the chopper to kind of lift that lens piece up out of the bag as well. So it has kind of two functions. I'm able to use the chopper to hydrodissect and then also to manipulate the lens. I'm coming in from a different angle and also pushing some more BSS with that obtuse angled cannula. Lift the incision with the chopper, go in with irrigation off to minimize Decime's trauma one more time. Now you can see the lens is much, much looser. I'm able to rotate that second heminucleus in front of me, placing chopper around the lens piece, crushing the lens completely in half, grabbing that third quadrant with some vacuum, crushing the lens between the instruments, and then emulsifying the lens pieces. Again, you can see this lens is rather stubborn. It doesn't really want to turn. So I'm using some vacuum to just pull that last quadrant up out of the bag. In this case, using some vacuum, again, in the central safe zone makes sense. Just grab it. I don't like to use too much ultrasonic energy. Just very carefully grab it and then get some purchase and then lift it up. Getting the fingertip around that lens piece, and then it pops right up out of the bag, and then crushing the lens between the instruments and then emulsifying the lens pieces. So again, really kind of like a sticky lens, not a terribly dense lens, like a 1 to 2 plus lens. Now I'm trying to remove the epinucleus. It's a little bit of a challenge because, as you know, this lens was pretty sticky to the capsular bag, so it's no surprise that the epinucleus is not wanting to come out. So I'm using the chopper to engage the epinucleus, pulling it centrally towards the central safe zone, hooking that peripheral epinucleus, and because I was able to do that, now I'm able to go after the fingertip and remove it with high vacuum. Again, this epinucleus is rather stiff, that's why it's not wanting to come out very easily. But again, very controlled, and I was able to do that in a very safe manner. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the ironing handpiece. I start with polish mode, polishing underneath the rexus edge, removing any lens epithelial cells. Polishing the posterior capsule as well. Oftentimes when the lens is rather sticky to the bag and it's really stubborn to remove, again, that just is a sign that there's just not very good hydrodissection right at that plane. And so once you remove the lens material, oftentimes there's just a lot of fine wispy material that I've noticed. So again, trouble turning the lens is still adherent to the capsular bag. Again, you worry about zonules, but also once you do remove the lens, in my experience, there tends to be a lot of fine wispy stuff. So you just have to go after that stuff and be patient. Again, I don't like to pulse into subincisional space when I can't see the rexus edge, so I go straight to the cohesive viscoelastic, filling the capsular bag. And in this case, I do plan to sweep a little bit, just in case there's some stuff in the subincisional fornix, just to check. And you can see there's stuff coming out. So, and again, you don't want to pulse with the BSS, no problem. You can use a sweep. It's a very controlled way. Once the eye is filled with OVD, you can polish underneath the rexus edge subincisionally and able to liberate that cortical material that's in the subincisional space. Now I'm able to place a single piece acrylic lens, place into the capsular bag. I turn the eye away from me so I can see the rexus edge. And I make sure that the lens is going underneath the rexus edge, so I'm confident the lens is in the bag. Go in with irrigation off, activate irrigation, making sure both haptics are off the optic. You always want to make sure that happens. If you don't, you could have an optic that's stuck to the optic and then the lens is decentered. So always check. If you don't check, you don't know. Always go in with the Maltzman with these small pupils, making sure that I double check the position of the lens, make sure both haptics are within the bag. It also allows me to protect the iris and the pupil when I do these maneuvers with the eye knee handpiece. I removed all the viscoelastic from within the bag already. Polishing underneath the rexus edge once again. Checking the lens position again, retracting the iris edge with the Maltzman. Switching to visco mode, and then I'll remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with a small pupil, 1 to 2 plus dense lens, sticky lens. It just wouldn't spin, kind of stubborn. It just didn't want to even fracture in some ways. And I had to re-hydrodissect. I used a chopper not only to re-hydrodissect, but also to kind of lift it out of the bag, use mechanical fracturing forces to very carefully and systematically disassemble the lens. Using cross chop, again, with cross chop, the chopper is a chopping instrument and the phaco-tip is a chopping block. So it just provides counterforce. It's not actively crushing. The only time the phaco-tip is actually crushing is when you're doing the double chop maneuver. And so again, very systematic, controlled removal of the lens. Even though this was a stubborn and sticky lens and it just didn't want to spin, I was able to carefully execute lens disassembly with these techniques. So at the end here, I'm hydrating my incisions. I'm checking the eye. It's nice and firm. I'm feeling pretty good about myself. But when I check the incision, it's still leaking. Still leaking, yeah. Normally I can see the shiny reflection when the incision is dry, but in that case you don't see that. And so that's my cue. When I use a cotton tip, I should see that shiny reflection off that dry incision where I made that vertical component of the incision. So when I don't see that, I go ahead and just hydrate the wound one more time. I'm going on the other side. You can see I'm hydrating the sides, I'm hydrating the roof. Everything looks like it should be sealed and it's executed perfectly. It was a good constructed incision, yet it's still oozing and leaking a little bit. It's not terrible. It's not like the chamber is unstable. Everything looks pretty good. Honestly, some people would probably just stop and just put a bandage lens and just expect it to seal up on its own. And again, there's nothing wrong with that. You could certainly do that and watch the patient closely with close follow-ups. But I don't want to be worried about these patients. I don't want to be thinking about their incision. I don't want to worry about, the patient might, have a problem or so forth. And so rather than worrying about that, it does take a few minutes. I just decided, I'm going to go ahead and place a suture. It's not a big deal. Swallow your pride. Again, not every tissue is going to respond to your surgery the way you're used to. And again, it goes to show surgery, things do happen. Placing a suture in the incision is not a big deal. But if it continues to leak and you have chamber instability or whatever, then that can be a big deal. So better to deal with it now at this time when you're doing the surgery versus if you have a problem, you'll have to say, oh, Mrs. Jones, sorry, but I'll have to take it back to surgery, and they're going to wonder what happened. And so, again, self-sealing incisions is great. You clear corneal surgery, and the way we've learned all these techniques have just been marvelous additions to our cataract armamentarium. But again, not every tissue responds. And even if you execute the surgery perfectly, you can have a leaky wound. Not a big deal. Just place a tenonylon suture, do the incision, and close it up. And now you don't have to worry. The patient will do great. Yes, it'll affect when you give them their prescription for glasses, because you have to remove that suture first, and you have to keep that suture in at least a week. And then usually by then it's all sealed up. And then you have to wait a little bit for that incision to relax, and then you'll have to give them the prescription for glasses. Yeah, it might be another visit, but at least you have the peace of mind that you did the right thing. And remember, the ultimate litmus test with any surgery is, how would you want to have the surgery performed if it was in your own mom or dad's eye or your family member's eye? You want to do your very, very best for every single patient. And that's another thing that I try to do. Anytime I hesitate about any decision I make, I ask myself, what would I do if it was my mom or my family member? You want to do the very best for every single patient. And I do tell that for every single patient. I will give them my all in all, my 100% attention, my 100% energy and effort to give them the most perfect surgery that is humanly possible. So again, this patient did very well. The patient had excellent vision post-op day 1, clear cornea, nice sealed incision, and again, no adverse effects due to the floppy iris syndrome. So I hope this was helpful to you, and I thank you for your attention.